system هنتكلم عن الليفر والspleen and the kidney. According to the Centers for Disease Control and Prevention, trauma is the leading cause of fatal injuries and the fourth leading overall cause of death. Accurate and early diagnosis, including grading of solid organ injuries after blunt abdominal trauma, is important to guide management and improve outcome. The American Association for Surgery of Trauma, AAST, Organ Injury Scale, OIS, is the most widely accepted blunt abdominal trauma scoring system at CT, both within the United States and internationally. The newly revised 2018 OIS provide criteria for grading solid organ damage into three groups: imaging, operation, and pathology. The final grade is based on the highest of the three criteria. If multiple low-grade 1 or 2 injuries are present in a single organ, one grade is advanced to grade 3. The most substantial change in the revised 2018 AAST OIS is incorporation of multi-detector CT finding of vascular injury, including pseudoaneurysm or AV fistula. Here is the main historical event in the creation of trauma grading scale. The abbreviated injury scale was introduced in 1971 for the American Medical Association Committee on Medical Aspect of Automotive Safety to improve vehicle safety, divide injuries into 6 category based on the degree of threat to life, from minor to not survivable. The AIS served as the foundation for the future trauma scoring scale. In 1974, the injury severity score was introduced for a better description of severity and the probability of death. In patients with multiple injury, it's based on the division of the whole body into 6 anatomic regions, with an AIS score assigned per region. If multiple injuries are present in the same regions, the most severe score is assigned. The ISS is calculated by adding up the sum of the scores of the 3 most severely injured regions. Severity scale has been shown to correlate well not only with the patient mortality but also morbidity and length of hospital stay. Then, in 1981, Abdominal Trauma Index was introduced, organ-specific estimating morbidity and mortality. 1989, the first AST OIS committee guideline, spleen, liver, and the kidney. 1990, Abdominal Trauma Index updated for blunt trauma. 1994, the first revision had been revised, and in 2018, that's the latest revision, and that will what will you talk today about it. CT is the ideal test in patient with a stable condition with suspected intra-abdominal injury with sensitivity for detection of visceral organ injury approaching 96 up to 100%. Extended focus assessment with sonography for trauma. So that's ultrasound is the initial screening test in all patients after abdominal trauma, especially those who are too hemodynamically unstable to undergo CT. It addresses a broad array of pathologic conditions include hemoperitoneum, hemoprecardium, hemothorax, and pneumothorax. The 2018 AAST injury scale advocates use of dual phase CT, arterial and portal venous phase. Arterial phase performed 25 to 30 seconds after intravenous injection of contrast, superior for pseudoaneurysm detection. The portal venous phase performed 65 to 80 seconds after injection and provides superior detection of active bleeding and parenchymal disruption. Delayed imaging 9 minutes after the portal venous phase needed in some cases, including renal laceration grade 2 or higher, substantial amount of fluid around renal pelvis, microscopic hematuria, pelvic fracture, or suspected bladder injury. Angiography and angioembolism are highly effective in controlling bleeding after blunt injury, which may be related to active extravasation, traumatic pseudoaneurysm, arteriopiliary, arteriovenous, or portopiliary fistula. Contrast-enhanced ultrasound shown to be almost as sensitive as contrast-enhanced CT in detection of traumatic injuries in patients with low-energy isolated abdominal trauma, sensitivity and specificity greater than 90%. Dual energy CT is another promising tool that allow characterization of various materials depending on their differential attenuation. MRI has limited utility in the acute trauma, setting to time-consuming, very expensive nature, and bullet and metal fragment containing steel or nickel may occasionally have place in follow-up of patient with major solid organ injury or additional tool for solving equivocal CT finding. For example, MRCP in diagnosis of injuries to the biliary system, pile leak, or biliary peritoneal fistula or pancreas. First of all, we'll talk about the spleen. The spleen is the most injured abdominal organ in blunt abdominal trauma. The splenorenal ligament connects the per area of spleen at the hilum with the left anterior perirenal space. Therefore, injury to splenic hilum can result in retroperitoneal plate in the anterior perirenal space, and the fusion of the left anterior renal fascia with the gastrosplenic ligament and continuation with the posterior renal fascia with diaphragm result in communication between them, leading to perinephric space and left subphrenic extraperitoneal space. Here is the grading system of the spleen. Grade 1 includes subcapsular hematoma spanning less than 10% of the surface area and capsular tear less than 1 centimeter in depth. There are no major changes are made to this grade in our revision. Grade 2 injury includes subcapsular hematoma spanning from 10% to 50% of surface area, intraparenchymal hematoma measuring less than 5 cm in diameter, and capsular tear from 1 to 3 cm. Here, if there was a category called trabecular vessel involvement was considered in the previous staging, but in revision, trabecular vessel involvement no longer consideration when assessing laceration, making size and depth is the only responsible factor for classification between grade 2 and 3. Grade 3 injury includes subcapsular hematoma greater than 50% of the surface area and the intraparenchymal hematoma greater than or equal to 5 cm, capsular tear with greater than 3 cm of parenchymal depth extension or ruptured subcapsular or parenchymal hematoma. The main changes, as we say, the removal of trabecular vessel involvement and discontinuation of the term expanding was used in the previous staging, but here no, there is no expanding term for subcapsular and parenchymal hematoma. For grade 4 injury include laceration involving segmental or hilar vessel, making devascularization more than 25% of the spleen. Any injury in presence of splenic vascular injury, AV fistula, pseudoaneurysm, or active bleeding. But here's the point, there is active bleeding contained within the capsule, not extending to the peritoneum. And to differentiate between them, how to differentiate is that an active bleeding or it's an AV fistula or pseudoaneurysm. The both in the initial imaging there is high attenuation focus. We must here proceed to the more sequences. If there is follow the blood pool, it's a pseudoaneurysm or fistula. What's that meaning? In the delayed phase, the AV fistula or pseudoaneurysm don't increase in size and there is no the high density no longer seen, but in the active bleeding no, there is increase, there is active extravasation. In this case there is active bleeding, so increase in size, increase in density. And here reaching to the grade 5 including shattered spleen, any injury in presence of splenic vascular injury, but here is active bleeding extend beyond the splenic capsule intraperitoneum. Here are some of the main changes brought on the 2000 update: splenic vascular injury or active bleeding confined within capsule or outside the capsule. And any vascular injury extend beyond the spleen is considered grade 5, while previous only vascular injury caused splenic devascularization were included. This division facilitated recognition of patients may benefit from splenic artery embolization. Addition of the arterial phase recommended in this version is responsible for increased detection of vascular injuries. In acute phase, splenic infarction will be seen as ill-defined area of decreased attenuation, but over time, the reason of infarction become more sharply demarcated volume loss. To reach the chronic phase, fibrosis or calcification may occur. For our management, non-operative management is preferred in most low-grade injuries from grade 1 to grade 3. Select hemodynamically stable high-grade injuries, grade 4 or 5. We may report cases of splenic injury, grade 4 or grade 5, and we find the physician or surgery say no, that's a stable patient and we will not proceed to surgery. Hemodynamic stability is the key point here in management. Presence of active hemorrhage, the most important predictor for failure of non-operative management. Contraindication to non-operative management include hemodynamically instability. That's the rule point. Even if we say there's active extravasation in this patient, the hemodynamic stability is the key point. Here is some cases for splenic injury after trauma. Here, We can see here in axial contrast enhanced CD image, there is a small splenic laceration, as we see in the red arrow, approximately 1 centimeter in depth. Here in the coronal image, there is a small subcapsular hematoma, red arrow, spanning less than 10% of the splenic surface area. Another note in this patient here, the left kidney, there is left lower pool subcapsular renal hematoma. As our grading system, this injury grade 1 splenic injury. Another case here, we can see in this red circle here in axial contrast enhanced CT image, 3.5 centimeter splenic intraparenchymal hematoma. And there is in RP images, there is that's a map image we do to demonstrate a 2.8 centimeter splenic laceration, the white arrow, and also there is hemoperitoneum noted in the posterior segment of the right hepatic loop. Axial contrast enhanced CD image in C images, there is a subcapsular hematoma spanning approximately 30-35% of splenic surface area. According to our grading system, it's grade 2 splenic injury. Our third case, there is axial contrast enhanced CD image show approximately 6 to 7 centimeter splenic laceration, seen here the red arrow, and in the axial contrast CT image here there is an intraparenchymal splenic hematoma, that's red circle, which communicate here with the large subcapsular splenic hematoma, which is spanning over 50% of splenic surface area. As we see here, there is blood reaching to the peritoneum. That indicates a rupture of this subcapsular hematoma. And we here, according to our grading system, that's a grade 3 splenic injury. Our next case, there is first image, there is a coronal image show active contrast material extravasation. That's high attenuation focus with red arrow, consistent with bleeding, but this bleeding it's contained with the splenic capsule. In the second image, the coronal contrast enhancer show a large laceration here of the upper pool of the spleen involving segmental vessel damage and resulting in greater than 25% devascularization of the spleen. And here in C and D images, there is an arterial and that's a portal phase. Show subcapsular splenic hematoma, red arrow, and the small contrast material attenuation, that's with the white arrow, which follows a blood pool, and that the main point to differentiate is that pseudoaneurysm or fistula, or that's an active extravasation. Here, this focus follow the blood pool, so this focus and wash out at the late image, and that's compatible with what you call a contained vascular injury. لا هما اخر كورس سي ان دي نفس الكيس، بس ده كان روتين اند بورتال عشان نشوف ال بالظبط، لكن الاذر لا دي other cases. And here our final case in the spleen, we can see here parenchymal disruption, hemoperitoneum, and active extravasation outside the splenic capsule. Here we enter this stage of grade 5 injury. There is active extravasation to the peritoneal cavity. So here we upgrade this to grade 5 splenic injury. What we see here that the patient portal hypertension from chronic liver disease is not related to the trauma. The patient was in this case treated with exploratory laparotomy and splenectomy. The second organ with us today is the liver. Liver, second most frequently injured abdominal organ and the most common cause of death in severe abdominal trauma. The right lobe injured 3 times more often than the left, and laceration, most common type of liver injury. Here our grading system for hepatic trauma. For grade 1 injury, we can see similarities but also differences between the liver and splenic injury. We will show that in this slide. The grade 1 injury includes subcapsular hematoma, less than 10% of surface area, and capsular laceration less than 1 centimeter in parenchymal depth. Grade 2 injury, subcapsular hematoma from 10% to 50% of surface area, intraparenchymal hematoma less than 10 centimeter. In the spleen there is 5 centimeter. And here there is capsular tear from 1 to 3 centimeter in depth and less than or equal to 10 centimeter long. The same as spleen. In this revision, no major changes made to this grade in 2018 revision. Grade 3 injury includes subcapsular hematoma spanning greater than 50% of surface area, ruptured subcapsular or parenchymal hematoma greater than 10 cm, laceration greater than 3 cm in depth. And here in grade 3 of liver injury, vascular injury with active bleeding contained within liver parenchyma. In contrast to the spleen, this kind of injury in spleen, a category 4, but here in the liver there is a category 3 injury. The major changes done in 2018 revision, including of the vascular injury with active bleeding contained within the liver parenchyma. And the same as the spleen, the expression expanding, no more used in our revision. Upgraded to grade 4 and grade 5. For grade 4 injury, parenchymal disruption involving 25 to 75% of hepatic loop and vascular injury with active bleeding extending into the peritoneum, in contrast to spleen, that's grade 5 in spleen. 2000 revision, inclusion of vascular injury is the major role of this revision, is the major focus of this revision. And here in the previous staging system, follow the anatomic classification system or conaid lobes. Here, no more use of this classification system or equivalent conaid lobes. Parenchymal disruption 25%, 75%, whatever the segment. Grade 5 injury, parenchymal disruption of greater than 75% of hepatic loop and juxtavenous hepatic injury. That's the most important in grade 5 injury, to see the juxtavenous hepatic injury, retrohepatic inferior vena cava or central major hepatic veins. For management for liver trauma, non-operative management appropriate for most mild to moderate grade 1 to 3 and 1/3 of severe 4 or 5 liver injury. The most important factor, the same as spleen, the hemodynamic status is the key point in all trauma case. And even if we proceed to 4 or 5, hemodynamic stability is the key point for the physician. Complications may include delayed hemorrhage, abscess formation, post-traumatic pseudoaneurysm, hemophilia, and biliary complication, pyeloma, bile leakage, biliary stricture, and bile peritonitis. Interventional radiology play a key role in management of many of these cases. Here is cases for liver injury. Case 1 for image axial contrast enhanced CT image, small subcapsular hematoma, this red arrow along segment 6, seen measuring 2 to 0.7 cm, less than 10% of the liver surface, no associated hepatic laceration. But in the case B, there is a small hepatic laceration, less than 10 cm in depth with this white arrow. According to our grading system, that's grade 1 liver injury. In second case, there is axial contrast enhanced CT image show intraparenchymal hepatic hematoma, red oval shape here, measuring around 3 to 4 cm at maximum dimension. In other image B image, there is a laceration in left liver loop, measuring almost 2 to 3 cm, no subcapsular hematoma or active bleeding. In the third image here, there is a subcapsular hepatic hematoma, this white arrow, spanning more than 40% of the liver surface area. According to our grading system, that's a grade 2 liver injury. Our third case, for the first image, there is a large intraparenchymal hematoma in the posterior right lobe, measuring about 5.5 to 3 cm with active extravasation, the high attenuation focus that we can see here, but no parenchymal, no capsular disruption. We can see that in A and P, and that's axial, and that's the coronal image for that. For the C image, that's another case that show a hepatic laceration, measure approximately 7 cm in length. And in D and E, there is a arterial and portal venous phase image. Multiple large liver laceration, we can see that the white arrow refer to this large laceration with contrast material attenuation focus. This red arrow, this contrast material attenuation focus, which push out in the portal venous phase and doesn't increase in size. So this suggests for contained vascular injury, pseudoaneurysm or AV fistula. Our fourth case, That's an axial contrast enhances CT image show a major disruption for right hepatic loop with active contrast material extravasation within the capsule and extending into the peritoneum. The red arrow here, that's a contrast extending into the peritoneum. For the other image here, there is approximately 50% disruption of the right hepatic loop, the red oval shape here, and hemoperitoneum is present here. So that's a grade 4 liver injury. Our fifth case, there is a CT image show over 75% right loop parenchymal disruption, partially visualized right side chest tube, that's the blue arrow, and subcutaneous emphysema seen in the right chest wall. In the axial contrast enhanced CT image, there is a gunshot wound. We know that from the ballistic trajectory extending from the right hepatic margin to the hepatic hilum, transecting the inferior vena cava. In the grade 5, there is the major thing that happened here is that the inferior vena cava or the major hepatic veins injury happened. So according to the grade system, it's a grade 5 hepatic injury. هو دكتور عشان هو هنا كده اللي هو الجزء ده اللي هو يعني اللي هو المسار بتاع التراجكتوري ان هو انا عارفه ان حضرتك محتاج طبعا بالسويبنج اكتر هقدر ان انا يبقى فيه ديفينيت هو بس هو بريدكت هنا في ده باعتبار ان المسار بتاع التراجكتوري كله ماشي على المسار بتاع الاي في سي لكن طبعا مع السكرولنج ده انا اقدر ان انا احدد ديفينيت في ديسربشن ديفينيت الاي في سي ولا لا. ما هو علشان ده من البلاستيك اصلا يعني ده بلاستيك تراجكتوري اللي داخل هو اكيد هيعمل لك ده بس هي دكتور اللي هو عشان ابقى شور ان الاي بي سي فعلا حصل له ترانزاكشن that's from not one picture هو surrounding it يعني surrounding it بس هي البوينت اللي هو that's a major thing to report مش هنريبورت it from one cut هي that's the point احنا محتاجين serious كامله لان دي major injury that's a fatal injury to report from one cut. The renal injury to the genitourinary system occur in 10% of patients with blunt abdominal trauma, kidney being the most injured genitourinary organ. Finding could raise suspicion for renal trauma include hematuria, flank or upper abdomen pain or hematomas, abdominal tenderness or distension, palpable mass, ecchymosis or abrasion, rib fracture, hypotension, and shock. Hematuria may be absent in ureter tear, vascular pedicle injury, or uretropelvic injury. That's the grading system for renal injury. Grade 1 injury include parenchymal contusion, subcapsular hematoma without laceration. Renal contusion appear to us as ill-defined patchy area of poor contrast enhancement during the portal phase, but in the delayed phase it becomes iso-attenuating, and that differs from the renal infarction. The renal infarction persists hypo in the delayed phase, not become iso-attenuating. Subcapsular hematoma are non-enhancing, hyper-attenuating في pre-contrast بنشوف hyper-attenuating, superficial, concentric or lentiform fluid collection, but it's contained from the in the renal capsule. When large, cause mass effect on the underlying renal parenchyma and in rare cases compress the kidney sufficiently to reduce the renal perfusion to reach a condition called page kidney from the major mass effect of the subcapsular hematoma. Distinction between the subcapsular and perinephric hematoma from the shape, the subcapsular hematoma retain the lentiform shape above the perinephric يعني بكون ill-defined بكون surrounding the kidney والsubcapsular hematoma when large exerting mass effect on underlying renal parenchyma. Its attenuation vary according to age, from hyper-attenuating in the acute and subacute stage to progressively iso or hypo-attenuating in the chronic stage. For the grade 2 injury renal injuries include perirenal hematoma, perinephric hematoma confined to the gluteus fascia, and laceration less than or equal to 1 centimeter in depth without urine leak. Presence of low attenuation perinephric fluid collection in acute stage should promote evaluation with delayed phase. ليه؟ عشان ده بيخلينا suspect ان في يعني collecting system injury وان ده urine او urinoma متكونه في يعني around الكدني يعني low attenuation لا ده suspicious ولازم اخد للبيشنت ده delayed phase. Grade 3 injury include parenchymal laceration greater than 1 cm in depth without collecting system rupture or urine leak, or any injury in presence of vascular injury or active bleeding but contained within the greatest fascia. That's considered a grade 3 injury. Active bleeding, here defined as focal or diffuse vascular contrast enhancement, the same conception, increase in size and attenuation in delayed phases, in contrast to pseudoaneurysm and the AV fistula. Grade 4 injury include parenchymal laceration extending to the urinary collecting system with urine leak, renal pelvis laceration, or complete uteropelvic junction disruption. Segmental renal vein or artery injury, active bleeding beyond the gluteus fascia into the retroperitoneum or peritoneum. Segmental or complete kidney infarction due to vessel thrombosis without active bleeding. Renal pelvis laceration or complete junction disruption can manifest as urine leak medial to an intact lateral callus on delayed images. Incomplete avulsion, no passage of excreted contrast material into the distal ureter, which may also be seen in partial tear if free fluid noted adjacent to the junction. Delayed imaging utmost important here in identification of this injury. Grade 5 injury include shattered kidney with loss of identifiable parenchymal anatomy, main renal artery or vein laceration, avulsion of the hilum, devascularized kidney with active bleeding. Shattered kidney result in multiple fragments and usually associated with urine leak and active bleeding. Here our first case for grade 1 renal injury. A and P. That was a motorcycle collision. There is a left renal ill-defined region of hypoattenuation consistent with renal contusion. To differ it from infarction, we could see the delayed phase. It become isoattenuating, that's renal contusion. Still as it is a segmental infarction. And for the C image, there is no evidence of laceration, but there is a left subcapsular hematoma. We can see here that's slightly facing the parenchyma of the kidney, so it's a subcapsular hematoma. Our second case says there is axial contrast CT image show a lucency less than 1 cm. It's very small, 1 cm in depth in left kidney, consistent with laceration, but there is no evidence of urine leak. For our second image, there is a perirenal hematoma. We can see here there is not the lentiform, not the so it's not a subcapsular, not lentiform, no any mass effect on the renal parenchyma. So that's a grade 2 renal injury. For our third case, for A, there is an axial contrast enhanced image. Thus, there is a left renal laceration, that's red arrow, with no urine leak, with a small perinephric hematoma seen. For the P image, there is a large left perinephric hematoma with active bleeding with this arrow, that's active bleeding. I know that's not obvious, very obvious here, but that's an active bleeding here seen contained within the greatest fascia. For the C image, there is axial delayed phase contrast enhanced image. This patient is another case was presented with flank pain and gross hematuria. There is a globular structure arrow here in the right kidney. There was a previous image, that's the light or sequence from the arterial and portal phase with high attenuation focus in this globular area. When we see here the delayed image, we see that there is iso, and is no high attenuation seen. So that's compatible with the contained vascular injury. It's not active extravasation, no, it's pseudoaneurysm or a fistula, it's a contained vascular injury. Our fourth case, for the first image here, we can see a left lower pool renal infarction. We know that infarction from the delayed phase, it is still the same in the delayed phase, not isoattenuating. For the P image, there is here a laceration of the right kidney extending from the anterior aspect through the pelvis, the blue arrow here, and to the posterior medial aspect with contrast material extending beyond the collecting system. You can see here the blue arrow extends. There is a small focus of high attenuation. That's contrast material that extending beyond the collecting system. That's contrasting with urine leak. No, we know that that's a urine leak from the pre, and if we see pre, that's hypoattenuating. See here the hypoattenuating, and there is a high attenuating here beyond the collecting system. And for the other case, for the C image, there is a complete left kidney infarction, no enhancement at all here, but no evidence of active bleeding. The kidney injury in this case was managed conservative, but with long term become non-functioning, even if there's a conservative treatment, but non-functioning at all after that. For RD images, there is a multiple severe right kidney laceration, a large amount of blood extending beyond the greatest fascia, and the contrast material extravasation, suggestive of active bleeding. Both here there is active bleeding within and into the peritoneum. Within, there is here the yellow arrow, there is high focus attenuation here, and that's within the greatest fascia, that's contained within the kidney. White arrow, there is a high attenuation focus that's beyond, it's into the peritoneum. And another case here in the E picture, there is a delayed phase contrast enhanced CD image, contrast material extending into the right perinephric space, and that's the blue arrow, and down to the right retroperitoneum. No contrast material seen in the distal right ureter. Not in this series, and while we scrolling the series, and that's a diagnostic for a complete uterine-pelvic disruption. And here there is axial contrast enhanced CT image show a shattered left kidney, two small fragments that is preserved after this trauma. That's the remaining from the normal kidney parenchyma, but loss of identifiable renal parenchymal anatomy and bleeding extending from the gluteus fascia into the peritoneum. Here see the blue arrow, there is a blood here in everywhere. Patient in this case underwent exploratory laparotomy and left nephrectomy. For other case, there is avulsion of the right renal artery hilum, right renal artery laceration in this red arrow, with extensive retroperitoneum and devascularized right kidney. The patient underwent right nephrectomy and avulsion of hilum and renal artery transection confirmed during the surgery. Here, why there is no active extravasation, there is a transection of the right renal artery, and we can see any active extravasation due to the vasospasm that happened from that transection. Vasospasm occurs to the vessel, so there's no extravasation we can see here. Most renal injury can be managed non-operatively with bed rest, frequent examination, and monitoring of vital sign, hematuria, and hemoglobin level. The renal injury grading critical to determine patient may benefit from more aggressive management. Increased re-interest with active bleeding, angioembolization should be considered. Perirenal hematoma size, contrast material extravasation, and the medial renal laceration site associated with increased need for urgent hemostatic intervention, but are included in the 2018 update. Complication of renal trauma, urinoma, urinary fistula, perinephric abscess, and hydronephrosis, recurrent pyelonephritis, kidney stone formation, pseudoaneurysm, AV, fistula, and hypertension. There is a summary for the most important changes that here in 2018, and overall the vascular injuries here is the mainstay of changes over grading. Liver, spleen, and the kidney. Who differ is it active extravasation, is pseudoaneurysm, or fistula, and the active extravasation, is it confined within the capsule or outside to the peritoneum? Because this, and when we differentiate those of physician, it's a mainstay. Is that embolization will be fine for that, or exploratory and laparotomy done? Thank you.